Hello, everyone. Welcome to our February ICARE Genetics Case Conference. I am Tua Pal. So here's the first case that uh, I've seen in conjunction with my colleagues here at Vanderbilt. So here you can see 30-year-old female, a paternal grandmother is the one who had the ovarian cancer. And that's what prompted the testing in her 22-year-old sister. Patient and her mother were subsequently tested, and both of them, so the mom and the two daughters both carry this the CDH1 pathogenic variant, and I've put in the details of the variant below. Um, Maternal grandmother was negative, so which means, we think it's coming from the maternal grandfather who is deceased and they had limited contact, so they didn't know much about it. So she was seen by one of my colleagues at Vanderbilt who sees most of our high-risk patients. There was a lengthy discussion, decided upon annual EGD with biopsy if concerning lesions, and is also getting high-risk screening per NCCN guidelines. So I wanted to kind of discuss this case with our guest expert. So it is my great pleasure to introduce Dr. Elena Stoffel. Um, Dr. Stoffel is clinical professor of internal medicine, University of Michigan. She leads the Rogel Cancer Center Cancer Genetics Clinic and coordinates surveillance for inherited GI cancers. And she has research that is focused on studying risk factors for colorectal cancer, but beyond colorectal cancer, also pancreatic cancer, and clinical trials for cancer prevention. So it is really a pleasure to have Elena join us for Case Conference and for us to learn from her, because I know that many of us are struggling with our CDH1 carriers and hereditary gastric cancer patients, especially with the evolution of the guidelines. So, Elena, would love your thoughts on this case.
Thank you so much for inviting me to be part of today's conference, and I am delighted to share with you my experience in managing these families because the case that you picked here is a perfect illustration of what we're seeing now. These are people for whom we never would have suspected that they would be at risk for hereditary diffuse gastric cancer. But I also want to tell you that from information that we are getting, these patients will still need to be managed really closely because their risk for developing gastric cancer is not zero, even though there's nobody in the family with gastric cancer. And so, in my discussion today, I'm going to impress upon you that patients like this really do need to have follow-up with and with a baseline endoscopy exam, with extensive gastric biopsies and review by an expert pathologist, because these patients are very likely to have in situ signet ring cell gastric cancers. The question is, what is the clinical implication of that diagnosis for them, and what's the best way to manage them? And so I don't have great answers here, but for this patient, I think a baseline upper endoscopy with Cambridge protocol biopsies, with review by an expert pathologist that is familiar with the staging system for identifying signet ring cells and making decisions about what to do based on the level of invasiveness.
So, Elena, I'm just going to ask another question. What we've struggled with is if you have signet ring cells, that's already quote unquote classified as cancer, right? Yet you expect to have them in the majority of CDH1 carriers. So, what we struggled with is, you do the biopsy and they have this cancer diagnosis, but we were expecting it. So it's kind of hard juggling that is what we've kind of found. And
Right. So I think that where the state of knowledge is right now is we're kind of in a place where prostate cancer has been in the past, which is virtually every CDH1 carrier will develop signet ring cells in their stomach. We don't find signet ring cells in the stomachs of people without CDH1 pathogenic variants unless they have cancer. But these signet ring cells, some of them are actually the majority of them are thought to be indolent, but some of them will progress and become invasive. The problem is that we don't know which ones are going to become invasive and which ones are just going to be indolent forever. And I think that that's where the big knowledge gap is right now. And in counseling patients, I think that that's the discussion, that it's only a matter of time before we find signet ring cells, but we don't know if those signet ring cells that we find are going to be indolent forever or whether they are going to progress. And we're trying to find information that will lead us to know which ones are more worrisome versus less worrisome. But right now, we rely on the patient's family history and we rely on the histopathologic evaluation of these signet ring cells.
Yeah, I think that yeah, it's I think you're exactly right. I think the what I've typically told patients in this setting is that um, um, that the finding the signet rings cells is that's it's less um, whether they're there, but when we can actually find them and prove that they're there, because um, if you look at particularly the Memorial series, then like regardless of whether, well, even in those patients who were biopsy negative by the Cambridge Protocol, like greater than 95% of those patients had microscopic foci of signet ring cells on final pathology anyway. So we know that those cells are there. Whether we are able to prove that or not is somewhat irrelevant. And so I think the challenge in in the current situation, as you said, is about it, and I use that exact analogy of prostate cancer when I talk to these patients now. But I think the where our situation is well behind the prostate cancer situation is that we don't have a PSA. There's no PSA for this situation, and so um, I think the most recent patient I saw with germline CDH mutation and and a biopsy showing signet ring cells was that we just got a CT scan and it's like, well, we're just looking for evidence of um, clinically relevant as has been now redefined disease. But I mean, does that is that is that I mean, it's clearly not good enough, right? Because it doesn't really tell us whether there's progression. Um, but I guess um, I mean the other thing that we could do is like a circulating tumor DNA. Is that something that is being looked at or is being used currently?
I have not seen any data on the performance of circulating tumor DNA in these patients, but that would be a good good potential study to see if there's anything you could pick up. I think that when I approach these patients, I usually talk about, the value of that baseline upper endoscopy, because at the baseline upper endoscopy, we can, if we take, the Cambridge protocol biopsies, the 30 to 40 biopsies from throughout the stomach, if we find signet ring cells in one biopsy, okay. If we find signet ring cells in multiple biopsies from multiple parts of the stomach, the argument is that the burden of signet ring cells might be a little bit higher. And if those signet ring cells that you find are showing evidence of invasion beyond that T1A stage, then there's widespread agreement that those are the patients that should probably be that are best treated with gastrectomy. I think that, the question is, what are you going to miss? And I think that we miss a lot in our endoscopic biopsies, which is why the data that we have, I think, also shows the value of repeated exams. Because the more exams you do, the more biopsies you do, the more likely you are to be able to assess if there are a lot of signet ring cells there, you're more likely to find them on repeated exams. And I think we are at a point right now, I think, where there's a lot of uncertainty. And I think a lot of us have taken care of families in which the proband is a 30-year-old with gastric cancer, with metastatic gastric cancer. And then you test her father, and he's in his late 60s and he has the CDH1 pathogenic variant. You do his endoscopy, you take a bunch of biopsies, there's nothing there, no signet ring cells that you find. And you're like, okay, well, why did she develop a cancer and he didn't? And there's probably a lot of host factors in terms of immune containment of some of these foci, which we don't have any data on yet. But I think that that's what makes these cases so challenging is that I think in the past we thought that people with a family history like this did not have a risk for gastric cancer, but now we know that that's not true, that there are signet ring cells in these patients, but whether the risk for progressing to a lethal gastric cancer is lower for these patients than for patients with a striking family history. I think that's what we're trying to figure out.
Hmm. Um, yeah. Yeah, I think that someone put I think it looks like Jacob put a question in about additional imaging, such as a PET scan. Any
There doesn't seem
utility?
to be any value for additional imaging. And even, I think that if you suspect that someone, if you're looking for metastatic disease, I think it's reasonable to do PET scans, but PET scans really don't have any value for surveillance of these patients.
What about endoscopic ultrasound?
Yep, that's been looked at, and it doesn't add anything.
And going back to what you said about determining changes in the burden of disease just on regular endoscopy. I mean, that sounds kind of very much a fuzzy kind of math kind of situation. Like, I mean, is there any sort of threshold at which like a certain amount of like just say half the biopsies or a third of the biopsies are positive? Is that like is there a percentage
There, there,
trigger that a percentage that will trigger like a total gastrectomy, you think?
I think it depends on who you talk to. In my practice, if I do an endoscopy with Cambridge protocol biopsies, I put the biopsies into separate bottles. First, I do a careful inspection to make sure to biopsy any visible lesions in the stomach. And I'm looking for white spots, I'm looking for ulcerations, I'm looking for erosions. I biopsy those and I put those in a separate bottle. Then I take the biopsies from the antrum in a separate bottle, body, separate bottle, fundus, separate bottle, cardia, separate bottle. And then I ask my pathologist to review these with, at multiple levels, looking for the signet ring cells. And we have one pathologist at University of Michigan who looks at all of these. So she uses the same methodology for each one of these cases. And then, what I'm looking for is, are there signet ring cells? And if there are, what is the stage of these? Are these T1A? So are these really superficial without any evidence of invasion? And secondly, are there signet ring cells in different parts of the stomach? So if there are multiple biopsies from the antrum that have signet ring cells, that's concerning to me. If there are biopsies from the antrum and the cardia, or the body and the cardia that have signet ring cells, that suggests to me that there's more of a burden of signet ring cells in the stomach, as opposed to if I just find one cluster of signet ring cells in one biopsy from one part of the stomach. I think that talking to some of the Europeans who feel more comfortable saying that what they're focusing on is simply the level of invasion of those signet ring cells, and if they are deeper than T1A, that's the threshold for gastrectomy. And I think that what we need to work on is we need to standardize these protocols so that we're all looking at the same thing, because I think especially in the endoscopy world, most of our fellow endoscopists don't know what we're looking for, and these findings are incredibly subtle. So there's been a lot of debate. Some of the Europeans suggest that focusing on just visible lesions is the important part of the surveillance. But I can tell you, in my experience, I find signet ring cells in those random blind biopsies where I don't see anything. I'm taking biopsies, and those biopsies from that were just non-targeted biopsies are often turn up in situ signet ring cells.
Yeah, that's extremely helpful. So um, in a patient who who already has a biopsy which shows signet ring cells and is obviously a CDH1 carrier, then um, how often do you get those follow-up endoscopies? It sounds like your
Yep.
strategy is to continue to screen them with biopsies if they're not going straight for gastrectomy.
I think that what I recommend, right, I recommend that all of our CDH1 carriers meet with a surgeon to just discuss the option of gastrectomy, just so that they know what the option is. I think that the data that's been presented by Jeremy Davis and his from his NIH cohort suggests that once we identify signet ring cells, the frequency of endoscopy should be more frequent, so every 6 months instead of every 12 months, and then just following much more closely with the hope that if there are more invasive foci, that we will see them. But
Yeah.
I think that
Okay.
this is all, in evolution, and the amount of follow-up that we have for these patients really from the NIH cohorts is mean follow-up of 30 months. So we're just talking about, less than 3 years of follow-up
Yeah. Yeah.
for
Sure.
many of these patients. So we don't know. The thought is that these signet in situ signet ring cells probably take a while to become invasive cancers, but we don't know how long that is. The importance of that first endoscopy is to see whether you see anything obvious there. And then on the follow-up endoscopies, the hope is that if anything is progressing, we will catch it in time to intervene. But I think that threshold for when to intervene is still up in the air. A lot of the European groups are getting much more comfortable with managing people, even who have multifocal signet ring cells in different parts of the stomach. I personally tell those patients that this is unusual, and this suggests to me that their burden of disease is maybe higher than most of the other people we manage. I think that the process of deciding if and when to have a prophylactic gastrectomy can take, several years, and that the findings on the serial endoscopy exams can help us determine whether your patient's signet ring cell burden is more than we would expect to see, or whether we do, 3 or 4 endoscopies and there's no signet ring cells on any of these. Perhaps they might be okay with surveillance, but I really hedge that with perhaps. We don't know. We're at a point of equipoise right now, I think.
Mm.
Which is why we're struggling. I want to get to your talk. There's two other questions here that I think will be quick. One is, are all gastric cancers that have signet ring cells technically considered a diffuse gastric cancer? I don't think it is, but I'll let you answer that.
Yeah, no, no. So diffuse gastric cancers are considered to be the gastric cancers that are basically that don't necessarily form a mass, but rather they spread, as linitis plastica. And I think one of the challenges with diffuse gastric cancers is that endoscopically they're often invisible, even in people with metastatic disease. You look at the stomach, and the stomach doesn't look particularly unusual. And yet the person has peritoneal carcinomatosis from linitis plastica. Signet ring cells can be seen in lots of different cancer types, but the recommendation is that any gastric cancer that has signet ring cells should be the patient should undergo germline testing for CDH1.
Okay, and then the other part of the question is, can you have diffuse gastric cancer without signet ring cells? Asking for purposes to know when someone meets NCCN recommendations for testing for CDH1, even if the pathologist doesn't use the term diffuse gastric cancer.
So I think that anyone with a diagnosis of diffuse gastric cancer would be worth testing for CDH1, and likewise anyone with signet ring cell gastric cancer meets criteria for testing.
Okay, and then here, scars from multiple biopsies from endoscopies mimic pale spots, white spots.
Yes. Yes.
Okay, so
And that's what
that
makes
gets
it
even
difficult.
more.
That's what makes it difficult. And I can tell you that I was just part of an effort run by a team in the Netherlands that was surveying endoscopists and showing us pictures of lesions and saying, how worried are you about this lesion? How would you classify this? And what do you think? And it's really humbling that, these things are so subtle. And the white spots from the endoscopic biopsies do look a little bit different from the other white spots that are kind of foci of in situ signet ring cells, but it's really subtle. And that's why I think one of my take-home messages is that, identify an endoscopist who is particularly interested in this field and have that person do all of the endoscopies because you learn by doing. And certainly you need to be absolutely meticulous and know what you're looking for.
Yeah, no, and most of our high risk patients are seen by one of our colleagues, our gastroenterology colleagues. So, yeah, that's what we're trying to do here. Other question, any specific knowledge on the Ashkenazi Jewish Q675 star variant?
I don't have any knowledge about that variant.
Okay. And then new pathology term is poorly cohesive rather than diffuse.
Mhm. That
Uh,
means these cells are not sticking together, right? And that's what E-cadherin is supposed to help those cells stick together. And when they don't stick together, they become they become poorly cohesive and they spread. Yeah.
Okay, I'm going to let you go on to your presentation just so we can get that done. And we have, I think, four more cases after that. So we'll get through as many as we can, but
Yeah.
take it
Well,
away.
yeah. All right. Well, thank you again. My main disclosure is that I'm a gastroenterologist and I perform endoscopic surveillance on patients with CDH1 pathogenic variants. So what I'm going to share with you today is going to be a combination of my clinical experience as well as sharing what has been published in the literature and what I've gleaned from discussions with other folks in the field who have a lot more experience than I in this space. So just by way of definition, right, hereditary diffuse gastric cancer used to be defined as one case of diffuse gastric cancer diagnosed before age 40, two cases of gastric cancer in first or secondary relatives with at least one confirmed diffuse gastric cancer, personal or family history of diffuse gastric cancer and lobular breast cancer with at least one diagnosis under age 50, and personal or family history of cleft lip, cleft palate in a patient with diffuse gastric cancer. So these were the guidelines for who should undergo genetic testing for diffuse gastric cancer. And in fact, many of the families that we used to test when we had to order gene-specific tests for CDH1 were families that look like this, right? So so take that 38-year-old individual whose mother had breast cancer and gastric cancer at 46, paternal or maternal uncle gastric cancer 61, another gastric cancer at 17, as well as additional diagnoses. And in talking with colleagues from New Zealand, including Sue Parry, a gastroenterologist in New Zealand, who managed a lot of the original Maori families in whom CDH1 pathogenic variants were originally diagnosed. A lot of the families look like this. There were teenagers who died of metastatic gastric cancer. And Sue's experience was that even though you were following these folks meticulously, doing upper endoscopies, the exams really didn't look very remarkable at all. And then a year later, somebody would present with metastatic gastric cancer. So these are some pictures from cases of diffuse gastric cancer, and as you can see, Linitis plastica often just shows up as a little bit of a reddened or thickened folds in the stomach and can be very subtle. So because in endoscopic surveillance of these families, there were people developing lethal cancers while under surveillance. The recommendation was made that CDH1 carriers should undergo total prophylactic gastrectomy, and this was the recommendation that was included in the international guidelines starting in the early 2000s up through 2020. So total gastrectomy with Roux-en-Y esophagojejunostomy is a big surgery. Removing an individual's stomach basically changes the way they eat and digest their food. And there can be a lot of side effects from this surgery. And groups from the NIH, from Jeremy Davis's team at the NIH, have also looked at the impact on patients who have undergone total prophylactic gastrectomy, and these include but are not limited to, distress and PTSD from surgery, chronic dysphagia and bile reflux, risk for gallstones and kidney stones and micronutrient deficiencies, and risks for bone loss, which are not inconsequential and require lifelong follow-up. So the question in this is that if you have the family on the left, right, where there have been many people who have died of diffuse gastric cancer, is it worth going through this potentially morbid surgery? Whereas if you're part of the family on the right, which looks exactly like the family you presented to me in that first case, where there's no gastric cancer at all in this family, and you have a pathogenic variant in CDH1. So should we manage both of these families with prophylactic gastrectomy? And I think that's where the field is changing. Again, up until 2020, the guidelines all said if you have a CDH1 pathogenic variant, you require a total prophylactic gastrectomy. And now it's a little bit more nuanced. So the question has come up as to what is the risk for gastric cancer in the setting of CDH1 pathogenic variants? What is the risk for lethal gastric cancer? And I think that one of the concerns when all of these CDH1 variants started popping up in our multi-gene panel testing was that the pedigrees started to look less classic for diffuse gastric cancer. And I think in studies that were published by Roberts and Cicola that used data from genetic testing laboratories, as compared to the historical cohorts where the lifetime risk for gastric cancer ranged from 60 to 80%, these cohorts, the risk for gastric cancer was roughly half that. And interestingly, the risks for breast cancer were actually on the high end of what had been reported in historical cohorts. And the idea was that probably reflects some ascertainment bias in that so many of the people who had genetic testing ordered were probably referred based on their personal or family history of breast cancer, which may be why the breast cancer numbers were higher than the gastric cancer numbers. And the other question was that maybe some of these gastric cancer diagnoses weren't being reported or were being ascertained incorrectly as perhaps, ovarian cancer, which can be very difficult to differentiate from, say, a widely metastatic diffuse gastric cancer. But I think that where we stand now in terms of the risks for diffuse gastric cancer in CDH1 carriers, and particularly for lethal gastric cancers, is that estimates suggest that the risk may actually be a bit lower. And so the NIH group, again led by Jeremy Davis, did a multi-institutional study where they kind of collected CDH1 families from many different institutions, and they tried to look at what the lifetime risk of gastric cancer was in these families. And their estimates came closer to about 10% lifetime risk of lethal gastric cancer. So all of a sudden, this kind of tips our balance, right? Because if we're talking about CDH1 carriers having a 60 to 80% lifetime risk for gastric cancer, or a 10% risk for gastric cancer, those are two very, very different numbers. And what I'm going to suggest to you today is I think that from looking at all of the data, the answer is somewhere in the middle. So it's probably not 80% and it's not 10%, but it's probably closer to, I would say, 20 to 40%. And there may be some differences in families which can shift some to the higher end and some to the lower end. So one of the other things that came from this large study that the NIH group led was that they looked at the risk for gastric cancer based on the family history, and not surprisingly, families that had more cases of gastric cancer had higher risk for gastric cancer, and that's where you start seeing the 40% estimates. Whereas families where there's no gastric cancer, that's where the risks seem to be a bit lower. So I think certainly family history can help influence those estimates. But, going back to that question, if you're the family on the right that has no gastric cancer at all, what is your risk of gastric cancer? Do you even need to worry about gastric cancer? And what do we expect to see on these endoscopies? Well, at University of Michigan, back in 2020, we started trying to answer that question of what do we find in the stomachs of people with CDH1 pathogenic variants who have no family history. And so we were doing endoscopies on all of these folks following Cambridge protocol, which many of you may be familiar with the recommendations for this, but essentially, this is a detailed endoscopic exam that needs to involve careful inspection of basically every inch of the gastric mucosa. You have to clear out the stomach meticulously, removing all of the bubbles. You start by insufflating the stomach to see if it looks like it inflates and deflates normally. Do those thickened folds flatten? And then you're supposed to do an inspection of at least 30 minutes of the gastric mucosa using both white light and narrowband imaging. And the goal of this is to identify any little thing that catches your eye. In particular, the literature mentions white spots and areas of ulceration or erosion, obviously any polyps or other masses. But even if something looks very subtle on endoscopy, the recommendation is biopsy that, put it in a separate bottle, and then proceed with random biopsies of the other parts of the stomach. And as I described previously, we take about 10 biopsies from each of the regions of the stomach and put them in separate bottles, and then have them reviewed by expert pathologists. And so what are we looking for, right? So this is an image that was included in one of the papers from the Dutch group that is trying to standardize what we're looking for in surveillance of CDH1 carriers. So as you see on panel A, right, there's a little bit of a white spot, right? This is incredibly subtle. I didn't put up a picture of a biopsy scar, but a biopsy scar might be a little bit more spiculated, a little more linear or spiculated than this little white spot. And the histology here shows you the typical cluster of signet ring cells that's T1A. And these are felt to be those indolent clusters of cells that are present in virtually everyone's stomach if you carry a CDH1 pathogenic variant, regardless of whether or not you have a family history. And that's the important part, is we find these in people even if there's no family history of gastric cancer. Now, panel C shows you a lesion that is a little bit more ulcerated, right? It's still a little white spot. It's got an ulceration or like a little erosion or ulceration in the center. And panel D shows you the biopsies of this lesion, which is actually this is a lesion that has more atypia. These signet ring cells are actually demonstrate deeper invasion into the muscularis mucosa. And so this is presumed to be the more aggressive type cancers, or the more aggressive type foci of signet ring cells, and these are the ones that require, or for which many individuals would recommend a prophylactic gastrectomy. So, right, these are really subtle differences, and I guarantee to you that if you ask our GI fellows about these, they would not find these. They would not see them. They would not find them. It wouldn't even cross their mind. And I think that this is why the importance is in counseling our patients. If they're going to have endoscopic surveillance, they really need to have endoscopic surveillance with an endoscopist who knows specifically what we're looking for. Because even I have trouble finding these, and I'm looking for them. And so certainly you want someone who's doing this really deliberately. So as I hinted to you in our University of Michigan experience, our yield of signet ring cells on endoscopic biopsies is exactly the same in families that were ascertained on the basis of a family history of gastric cancer versus those that were just identified on multi-gene panel testing. Those signet ring cells are there in the stomachs. The question is just how many of them are there? What's the burden? And are they developing any of these atypical features? And I think my impression is that right now that may depend very much on the individual patient that you're seeing. There's no good predictor. There's no good rhyme or reason. And this is why the meticulous, if we're going to do meticulous surveillance, we have to be really systematic about it. So this panel shows us a little bit about some of the data that we had published back in 2019, that was looking at the yield of signet ring cells based on the family history. So on the x-axis, there's the number of relatives with breast cancer in the family, and on the y-axis is the number of relatives with gastric cancer in the family and first and secondary relatives. So as you can see here, it's kind of all over the place because everything that's shaded in red is basically signet ring cells. And so they're all over the place, right? There's people with no relatives with gastric cancer who have signet ring cells. And then there's people who have several relatives with gastric cancer who don't have signet ring cells. So a lot of this, I think, is what we're finding and what we're missing. So how good is endoscopic surveillance? So if you think about it, in this study that came out of the group from, I believe this was the group at Mass General, they actually estimated that if when you go through and you section the entire stomach for these CDH1 carriers, you find signet ring cells in about 90% of these individuals. And they estimated that if you were going to do endoscopic biopsies here, you would have to take with a detection rate of 50% for signet ring cells, you would have to take between 50 and 5,800 biopsies. So this is part of the justification for why serial exams may be helpful, is that the more biopsies you take, the more chances you are that you're getting representative picture of the entire gastric mucosa. And so if there are worrisome clusters in there, you're more likely to find them the more scopes you do. But it's not perfect and there's no guarantee. So in talking about how these T1A indolent clusters of signet ring cells are found in at least 80% of CDH1 carriers, what makes these turn into the more aggressive invasive signet ring cells? And so that's the million-dollar question. And there are groups at Rebecca Fitzgerald and Massimo Di Pietro at University of Cambridge in the UK are actually doing some work trying to look at some of these invasive clusters to see if there's any potential biomarkers of these cells that suggest what properties they acquire to become more invasive. But there isn't any clinical testing at this point other than kind of looking at them. We don't have any particular molecular markers that we're using to be able to tell if these are going to be aggressive or not. We don't know what risk modifiers there are, and we certainly don't know the timeline that it would take for something to go from indolent to being aggressive. So that's the rub. So again, we're doing endoscopic surveillance. We're looking at these things. We're taking biopsies. And then, and that's kind of where we are. If you're having surveillance, that's where we are. So what basically tipped the balance in making us pull back a little bit from the recommendation that everybody needs a total prophylactic gastrectomy are the data that came from, as I mentioned, Jeremy Davis's group at NIH really became a referral center for endoscopic surveillance for patients with CDH1 pathogenic variants. And Jeremy and his team engaged on serial surveillance exams of 270 CDH1 carriers with an average follow-up time of 31 months. And in their cohort on endoscopic biopsies, 63% had clusters of signet ring cells, but many of these required serial exams to find those signet ring cells. So they might not have been present on the first exam, but they were found on the second or third exam. A total of 98 of these individuals, so about a third of people underwent gastrectomy, and 93% of them had T1A signet ring cells in their stomachs. 2 individuals had T3 gastric cancers, right? So T3 gastric cancers are the ones that absolutely no question these needed to be resected. And in the cohort, there were no gastric cancer deaths. So the conclusions of this study were that this demonstrates to us that surveillance may be an alternative to prophylactic gastrectomy for these individuals, because the fact that nobody died from lethal gastric cancers while they were being followed argues that surveillance could be safe. The caveats here are that the follow-up time on average was only 31 months. And so we don't know what happens at that, 5-year, 10-year mark. And so I think that that's where we are going to get a lot of natural history data as individuals decide whether to undergo a prophylactic gastrectomy or to proceed with surveillance. So based on the NIH experience, and just to mention the NIH, Jeremy Davis left NIH and he's now at University of Maryland. So that entire surveillance system from the NIH disbanded and all of those patients got referred back to their local doctors. So there's really a lot of anxiety on the basis of many of these patients looking for who can follow them locally in the same way they were followed at the NIH. So this is what the Jeremy Davis and his team from NIH are recommending, which is that, high quality endoscopy with with visual inspection and lots of biopsies. If there's anything concerning on that initial endoscopy, if the stomach doesn't distend normally, if there's really thickened folds, if there's ulcerations or erosions, biopsy all of that. And if those biopsies turn up signet ring cells that have worrisome features or that are more than T1A, those are the patients that need gastrectomies. And so that's where kind of the imaging comes in. You can do your preoperative imaging before they go to gastrectomy to try to figure out if there's anything that you see there that's going to change your operative management plan. If the biopsies are negative for signet ring cells, you basically follow them up. And typically, in my experience, I refer everyone to meet with a gastric surgeon just to get the information of what a gastrectomy would involve. If they opt to continue surveillance and their biopsies were negative for signet ring cells, annual endoscopy where we do it all again in a year. If the biopsies are positive for signet ring cells, but those signet ring cells don't have any of the worrisome features of being more invasive, of being beyond T1A, then the surveillance interval decreases to every 6 months. So in summary of our clinical experience, of my clinical experience at University of Michigan and the experience, the larger experience of both the NIH cohorts, colleagues and larger international cohorts, probably at least 80% of individuals with pathogenic CDH1 variants have signet ring cells in their stomach or gastrectomy specimens. And these signet ring cells can be there even if there's no family history of gastric cancer. So half of individuals with signet ring cells in our experience had a previously abnormal, who went to gastrectomy, who had a normal upper endoscopy in the past, and there were still signet ring cells on the gastrectomy specimen. Half of people who had signet ring cells had no family history of diffuse gastric cancer. And one of the people that we actually did a baseline surveillance exam on that found signet ring cells actually had a T3 gastric cancer that I did not see on my endoscopy. And it's because these cancers are infiltrative. They don't form masses, they don't form ulcers. And this was a cancer up in the gastric cardia that even though we took biopsies from around there, I didn't see that cancer, and that cancer was only seen on the resection specimen. So these things are very difficult to see and you can miss them. We have no reliable clinical predictors for who's going to develop gastric cancer. Biological sex, screening age, mutation type, and personal history don't seem to predict the risk for diffuse gastric cancer. There are data showing that if you have more cases of gastric cancer in your family, your risk may be higher. But just because you don't have any gastric cancers in your family doesn't mean that you're not at risk. And certainly, as I mentioned, we have some, heartbroken families where the first proband in the family was somebody who died of gastric cancer in their 30s. And everybody else in the family who carries the mutation is, well into their 70s with no gastric cancer. So there can always be a first in the family. So, where do we stand now for managing risk for hereditary diffuse gastric cancer in CDH1 carriers? Well, the International Gastric Cancer Linkage Consortium, so the group that originally said prophylactic gastrectomy for everyone, revised their recommendations so that recommending they still recommend considering total prophylactic gastrectomy in their 20s, but they also added the caveat that annual endoscopic surveillance with total gastrectomy if biopsy positive. More recently, the NCCN guidelines have basically put up the option of shared decision making to discuss surgery versus endoscopic surveillance, with a feeling that there's relative equipoise here. Patients should understand the risks and benefits of a gastrectomy as the most definitive way to reduce their risk for developing gastric cancer. But for people who opt not to undergo prophylactic gastrectomy, endoscopic surveillance with the targeted protocols of targeted biopsies and random biopsies every 6 to 12 months. And considering, and then with the recommendation for gastrectomy, if you identify signet ring cell adenocarcinoma that is at that more aggressive end with atypia, which is considered beyond stage T1A. So, back in 2020, the modeling studies were trying to determine, what does your gastric cancer risk have to be to favor prophylactic gastrectomy. And in this model, the idea was that if you assume that your risk for diffuse gastric cancer is 50 to 60% over the course of your lifetime, this is where it makes sense to undergo total prophylactic gastrectomy. And the optimal age in this decision analysis was for women around age 30, for men age 39. But, the more recent reviews that have been published, and this is a particularly good one that I want to point you to, that was published in the JNCCN in April of 2025, that basically states where we are right now, which is more of equipoise. So the penetrance of advanced gastric cancer is lower than previously reported. T1A signet ring cells are nearly ubiquitous in CDH1 carriers and do not necessarily require immediate gastrectomy. Total gastrectomy carries risk for serious complications and can significantly impact quality of life, and endoscopic surveillance at 6 to 12-month intervals may be a reasonable alternative in the absence of disease beyond T1A. And so that's the diagram on the right, is those T1As are basically signet ring cells that are confined to the lamina propria, but that do not involve the muscularis mucosa. So, the Dutch, as I mentioned, are trying to really standardize and to make sure that everybody's clear on what a T1A signet ring cell cluster looks like, as opposed to those T1s that have atypia or the beyond T2s. And so I think that this is where I think our pathologists and our endoscopists all have to get on the same page so that we're all speaking the same language and we know what we're dealing with. Because the T1As, many people are now comfortable with following, but if you start getting those features of atypia, or you start seeing that there's invasion beyond the lamina propria into the muscularis, everybody's pretty clear that those patients should be referred for gastrectomy. So shared decision making, and this is the rub, right? This is when we're talking to patients in clinic, is, there's a lot of reasons why people may want to opt for surveillance, right? If you're particularly worried about surgical side effects, and the morbidity of surgery is not inconsequential, as we discussed before. If you don't have endoscopic expertise that can reliably identify some of these high-risk lesions, certainly people who have comorbidities that will not allow them to be good surgical candidates. That's where surveillance might make sense. But I've certainly had patients who are absolutely adamant that they're going to have surgery as soon as possible. Particularly individuals who have had family members die at young ages of gastric cancer tend to be very, very accepting of surgery. And also people who say that they can't sleep at night because they're thinking about their risk of cancer. And I think it's really important that we think about, for our patients, what is the level of endoscopic expertise available? What is the level of surgical expertise available? And this is often a process that takes, as I mentioned, many years. Like these are the patients who send me portal messages and say, "Can we talk? I know we met a month ago. Can we talk again?" And I think that there's a lot of work in the genetic counseling world to try to identify if there are better if there are decision aids or better strategies that we can use to help counsel patients to help them make the right decision for them at the right time. So again, what we know, nearly all CDH1 carriers have foci of signet ring cells. Diffuse gastric cancers can develop in CDH1 carriers even when there's no prior family history, and survival in diffuse gastric cancer is poor. What we don't know is what determines whether signet ring cells transform into diffuse gastric cancers, what factors modify cancer penetrance, what strategies improve early detection. I think it's expert endoscopists and expert pathologists. And then the time frame for developing advanced disease. And then, as I mentioned, the analogy to prostate cancers, right? So CDH1 carriers are all going to have signet ring cells, but what's going to make those signet ring cells develop into other cancers? And can we distinguish between indolent and aggressive signet ring cell foci? So for future directions, we need mechanisms, right? We need mechanistic studies to identify what is the switch that flips in some of these signet ring cell clusters. We need to be able to validate the endoscopic and histopathologic staging. We need to be able to assess the utility and generability of biopsy protocols and or biomarkers, and then personalizing risk assessment. What is the role of family history and the other genetic or environmental risk factors, right? Because part of this is maybe it's your immune system, right? Maybe it's people's immune system that's more likely to contain some of these lesions as opposed to let them progress. And so a lot of excitement about potential for chemoprevention, biomarker studies, and artificial intelligence to be able to aid endoscopists and pathologists in finding these clusters. So I think that's all I have for so far. Thank you so much for your attention, and happy to take any questions if there's time.
Yeah, thank you, Elena. I was looking at the time, but your presentation was awesome because I think this is such a huge area that we're all really struggling with. There's multiple, yeah, multiple people thought your presentation was excellent. So I think all across the board, you just provide us, I mean, some of the unknowns I think are also important to define, and that's what you have done for us. And beyond that, it's almost like it's a team effort, right? So if you don't have the right team with an experienced GI or gastroenterologist, with an experienced pathologist, with a surgeon that also is familiar with what's going on, it's very risky to go the screening route. I mean, that's kind of the main message I got here. And family history is not necessarily going to tell us everything we want to know. I was thinking, I know we're over time, but Nina has a case. So I was going to do the one case. And then, in the meantime, if anyone, Marcus, I don't know if you have any questions for Elena, and then we can go on to Nina's case. And we will be a few minutes
Um,
over.
I don't want to take too much time because I talked a lot before, but a fantastic presentation. I think it's a fantastic summary of where the literature is currently. And I guess my one quick question would be, are there any kind of national kind of or even institutional trials or like whether of screening or of other biomarkers that are currently ongoing?
Um, so that's a great question. And I think that I don't know of any actual trials that are ongoing now, but at this year's Digestive Diseases Week GI meetings, there's going to be a particular focus on gastric cancer. So I expect that there'll be some more information presented there. I know that the group in the UK at Cambridge is doing a lot of molecular testing on their biopsies. So I think that the hope is that they might have some data to share on whether they have enough information of characteristics of biopsies of people that went on to progress to more advanced lesions versus those that didn't. But I don't know of anything ongoing right now. There are efforts underway though to try to do collaborative studies to compile and pool data. And Sonia Kupfer and Ophir Gelad at University of Chicago have a consortium called Gastric that they're including. They're inviting people to contribute their data on outcomes to be able to look at outcomes. But I think you're right. The next step is going to be looking at, are there biomarkers? Are there circulating tumor cells? Is there something that we can do that can add some prediction?
Okay, so I'm going to hand it over to Nina to present this case.
Hi, I'm a genetic counselor. I'm South African, and this is a patient that I saw in my private practice in South Africa. She was referred to me. She's 39 now, and originally her mom was actually referred to me to get testing for her bilateral breast cancer, and we did just a 16 gene breast cancer panel on her. Didn't find anything in her, and then her daughter was really worried about her grand's breast cancer in her 40s on her dad's side, so she came to me and she said, "Can we test me too?" But she wanted to do sort of a broader panel testing. And then, fortunately, unfortunately, we found the ctNNA1 pathogenic variant in this family that had absolutely no gastric cancer. I have subsequently gone back and tested the mom and confirmed that the mom is the one that had the ctNNA1 variant. And so this was a couple of years ago. I think it was in beginning 2023 when we did this testing. And she comes back to me every 2 years to just be like, is there any updated advice? At the time, I had done some reading, and what I could find was sort of annual endoscopy and, could consider could consider surgery, but not necessarily, recommend it because we don't know a lot about this. And just because of her family history of breast cancer, the mom also had a lobular breast cancer. I gave her sort of high risk breast cancer management recommendations. And in South Africa, screening isn't always as available. So the conversation was around potentially considering prophylactic breast surgery. She hasn't done either of that, as far as I understand. She's had some biopsies in her stomach in about a year ago, and she has to follow up again with that. But I was just wondering what other people are doing with ctNNA1s because I guess the information about it is even more limited than CDH1.
Yes, absolutely. So I think that the consensus right now, and this is kind of from talking to colleagues, and then Perry Guilford has a great review from just this year, and everybody feels that CTNNA1 might have a phenotype that's much milder than what we would expect to see in CDH1. So they can share some of the same features because the pathophysiology is a little bit similar in that you are kind of losing the cell-cell adhesion and e-cadherin. But in ctNNA1, the estimated risks for both breast cancer and gastric cancer seem to be quite a bit lower than you would anticipate for CDH1. So I think at this time, and we follow a couple of ctNNA1 families, we're doing endoscopies with Cambridge protocol biopsies, but not recommending gastrectomy. And we haven't found anything worrisome in any of them yet.
That's good news. Dr. Stoffel, and just if you say you have a few of these families, are those people also following high-risk breast protocols?
Yes. Yes.
Okay. Okay.
Yep.
So high-risk breast protocols do make sense in cases like this.
Yep.
Okay.
Yep.
And I just wanted to put a plug in. I think Bryson Katona has a grant where he's actually collecting these patients. It's in the chat. I think Nicoletta put it in the chat. So again, I would encourage these people to get into these registries because that's the way we're going to figure out what is going on. Like Elena already said, the penetrance looks to be much lower, but they're still getting like these gastric cancers. So I think more to come on that. Okay. I know we have more questions. Elena, I'm probably going to ask you to come back at your convenience to discuss this very, very popular topic.
Yeah, I would say maybe after the GI meetings in May, because that's where everybody's going to be talking about
Yeah,
what's
no,
new
I'd
in
love
the
to
field.
because we have a bunch of cases that we were going to present, but your presentation was fascinating because again, I follow the literature. I learned a ton. So thank you so much for doing that.
Thank you for inviting me.
So we're continuing to have a great lineup. So upcoming case conferences in March, I have Dr. Kelly Metcalf talking about PALB2 updates and with a focus on contralateral breast cancer. And she's got some interesting new data to present as well. And then in April, we have my colleague at Vanderbilt, Dr. Alex Bick, talking about clonal hematopoiesis versus hereditary cancer, which again is a very hot topic that I know many of us are struggling with as well. So with that, I thank you for attending. Dr. Stoffel, many, many thanks for your expertise and your presentation, and we will see you all soon again. Bye.